It's a very interesting topic because all of us we get club food and this is the commonest pediatric problem. Club food is my thesis topic as well. I am treating club food from 1991 only with external therapy. I have not opened any club food so far, not a open surgery, but I had assisted many open surgeries to very well-known pediatric orthopedic surgeons, but I don't know the cost of the divisions. As you know, most of these things I have learned from these guys. Coming to the incidences of the congenital club foot, it is 1 to 6 cases per 1,000 live births. The ratio changes from country to country. Boys outnumber the girls. Congenital club foot has got different etiology. That maybe no one knows the etiology. It is a polyetiological. Sometimes there are endogenous factors, sometimes there are exogenous factors. Some say that there is some uterine band, some pressure, some reduced or increased pressure during the developmental period, hereditary. All these are so many causes are there. Nearly 55 to 62% of the cases of club foot we see bilateral. Maybe 2/3 of the cases and 1/3 unilateral. In the classification of the club foot, typical club foot, that is again subclassified as mild, moderate and severe depending upon the elasticity or the correction. Then complicated club foot like arthrogryposis, achondroplasia, torsion of the tibia, fibula, neurogenic club foots and complications. The recurrent cases which are developed after the treatment of severe or complicated forms of club foot, usually by conventional treatment modalities. So we get very less amount of cases, nearly 40% of the fresh cases, but most of these cases are referred or recurred or dropouts of earlier treated cases somewhere else. See the length of the foot, it amounts nearly 15.5% to the height of the person. In our experiences, nearly 345 patients till now have treated 41 fits. So this is congenital club foot, a very severe variant of the congenital talonavicular dislocation. So, as I told in the beginning, if the deformity is chronic and deformity is severe, then you have to address it very gradually and sequentially. So, this is the principle of this lecture. And Ilizarov permits that thing. Very accurate force application, gradual and sequential correction of all these deformities. It is subluxation or dislocation of the calcaneonavicular joint causing severe equinus, varus and adduction of the forefoot. It gives adduction of the forefoot at metatarsovarus and in internal flexion. This is the way how the club foot deformity is there, and in standard X-ray the club foot, it looks like this. Of course, I am not telling that immediately you should go for any kind of surgical intervention. So I told you the protocol. So club foot is a severe deformity. As soon as the child gets birth, you should start treating that patient. First and foremost important thing is the counseling of parents. Very often the gynecologist they call me to see the patient and they tell us why this doctor did not tell us that our child was having a club foot. Okay? But believe me, if there is a club foot and even the binoculars, they know in the ultrasound that is not the indication for abortion, as it is a treatable congenital anomaly. But that is a shock to the patients and to the relatives that their child is born with a crooked feet, isn't it? So you have to initially counsel the parents. You should tell them treatment protocol and outcome. Initially, for 3 weeks, I tell them gentle exercises, manipulations. Then after 3 weeks, I try the stamping. Then once the child grows, maybe after 1.5 months like that, when the skin condition permits, put the cast. Even I try to 1 or 2 sittings of the cast. But when I know that if the moderate to severe or conditions like arthroporosis, there is no need of wasting any efforts or time. So what are the disadvantages of the conventional methods to treat the club foot of any origin? It very often causes the recurrence, and the reason of recurrence is the whenever you put a knife on a deformity and correct it acutely, that due to the re-elasticity, it again rebounds. Big and lasting ugly scars are there. Those scars, they increase with the age of the patient. You cannot correct the length of the foot by conventional methods. That is the major drawback if you are not treating a club foot by external fixation. You might get painless, pliable, plant figured foot, but the foot will not be cosmetically accepted at all. Whenever the patient is of 2 years, 3 years, parents will not find out much difference in the foot. But if it is a unilateral foot, after the skeletal maturity on one side, the guy will read number 7, number 8, number of the shoes, and the other side 5, 6 like that. And there is a gross discrepancy in the both of it, and that is the major drawback of plastering techniques or these conventional treatment methods. And this cosmetic aspect is extremely important, and nobody in any book or nobody gives lecture or advocates their method has commented or considered this. Cosmetic appearance or equality of both the foot is extremely important. Why? Because if my son or daughter is suffering from club foot unilaterally, every time if I go to buy any footwear, he or she will have to wear 2 pairs, number 8 for left and number 6 for right. Isn't it? That is the big problem. As well as it looks deforming in regular social life. It is cosmetic appearance of the equality of the both the feet is extremely important. Procedures are lengthy, and whenever you try to correct this severe deformity, you sometimes encounter skin or nerve problems. So there is a very basic rule of deformity correction which applies here also. Any long-standing and severe deformity has to be corrected gradually and sequentially. So I had treated up till 2014 nearly 344 cases. So most of these cases were severe, recurrent, resistant or late presentation or even untreated cases. Most of these were inadequately treated. That means the surgeon got satisfied with some correction and then it was left, then the parent also dropped out the defect. The age limit for the application of the external fixator, I am not only talking about Ilizarov fixator, I am talking about use of external fixators in treating club foot. 3 months to 12 years we operate by external fixators, but whenever you need to apply Ilizarov, 3 years onwards. These are the indications: moderate to severe club foot, resistant, untreated relapse or dropouts. So this is the age distribution which we treated. Now coming to the methods. So primarily I use 2 kinds of fixator. One is just That is the Indian type of fixator invented by Dr. B. Joshi from Mumbai. He is no more now. The principle is controlled differential fractional distraction. Controlled means you have got a control for that direction. Differential means medial side more than the lateral side. Not 1 millimeter on medial and same equal on the lateral. You understand these wordings. Fractional means we do it in fractions, not continuously. Distraction means you are distracting. So this is the basic principle. Control differential fractional distraction is used to correct the deformity by gradual differentiation of the soft tissue. It gives correction of the soft tissue. This fixator is not that strong as Ilizarov, you can see. This is a two-dimensional fixator made out of only regular KYLs, 1.5 to 3 mm, and with this jet rods, straight rods, these two distract posteriorly, two on medial and lateral side, one on the other side, holding calcaneus to metatarsal and this calcaneus to tibia. And such a connecting frame is not that much sturdy. That's why I use this frame only for the up to 5-6 years. Whenever there is a patient use permits me, after 3 years I go for the Ilizarov fixation. But definitely before that, even from the 3 months onwards, I use this kind of chest fixation. And if anyone wants to buy that, we have this fixator here also. The assemblies in bolts and tibia calcaneus and calcaneum metatarsal ports, and these are the distractors. Tibia calcaneum posteriorly, two, and a calcaneum metatarsal, one on medial, other on the lateral side. So this correction is only two-dimensional. He is late Professor Dr. B. Joshi from Mumbai. He invented mini hand chest fixator and which can be used even for the correction of the pediatric deformities and club foot like this. You can see this is my thesis topic and this is his signature. I worked with him for 1 year in Mumbai. So this is what it looks like. It is a good fixator, cost effective, lightweight, and even results are quite promising, and it's very simple surgery problem. Not much complicated like Ilizarov. So these are few of my cases. Bilateral club foot fitted by chest fixator. During my thesis topic, I was not having enough funds to apply simultaneously. So here you can see on one side fixator is used, and you can see the correction, and after that the same fixator is done on the other side. Only here the pliable plantigrade correction is achieved in the soft tissues with some dots on the KYLs. Cosmetically it gives good results. Of course, everything you have to document with pre-op and post-op X-rays. In another case, after removal also you should splint it. The 7-year-old girl with a failed and recurred open surgery with a big scar. We get 3 sizes of the chest fixator, small, medium and large as per the age groups. This was again 12-year-old girl, untreated with big calloused on either side. You can see here the rods and all, they are not much strong, they tend to bend at that age. This is a unilateral neurogenic club foot. She was a medical student, 19-year-old girl, treated by B. Joshi himself. This is not my case. But you can see here, this is not a case for this kind of fixator. It's a very labbing fixator. Cannot give hold to correct such age. That's what I'm taking. Maximum up to 10 to 12 years. Maximum. The best is from 3 months onwards to 6-7 years onwards. Good. These are all my cases only. Here also you can see this gel rod has turned like this. Due to over distraction, these are not strong, so they tend to bend like this. This guy is from Pakistan. As I told that in many cases are there. Likewise, I operated this chest fixator also in Pakistan. However, this is the first case of chest fixator applied to club foot in Pakistan. Coming to the method, in Ilizarov, it permits accurate force application to individual part of the foot because the chest fixator lack application of the hinges. Here you are applying the hinges exactly at the level of the deformity. It gives combination of the compression and distraction. The assembly is the circular ring frame with tension bands. As I told before, 3 years you cannot tension the band. That's why it is used only after 3 years, and it's the hinge distraction, and it gives 3-dimensional correction in club foot. If you want rotational, then it becomes a 4-dimensional. This is a schematic way how this foot gets corrected. This is the way how you can apply. And whenever the foot deformity is very severe, we don't do any bony corrections up to 12-15 years. But after that, whenever there is a club foot, you can go for such kind of osteotomy or calcaneus to correct the foot deformity. This is a diagram how to correct it. Everything is given in the book. Don't waste your time in taking. Everything is on the net in the book and all. Just concentrate on the silent features. In the collapsed foot, you can see here 2 ugly scars treated unilaterally by Ilizarov. In one case, comparatively I did with chest and Ilizarov. Results are almost same as the patient was around 8-year-old. Even in the polio club foods or post-traumatic club foods also you can use this technique. As a protocol, we do psychiatric counseling of the patient as well as counseling of the parents. We put external fixator as per the requirement and the age with closed tenotomy. Okay? Tenotomy of the tenoideus as well as the right plantar, and then we apply. We do differential distraction on the medial side, double than that of the lateral side. That means once it is a deformity is like this, on medial side we have to distract more than the lateral comparatively. Regular follow and regular tracing is extremely important. We assess the correction during the visits, clinical and radiological assessment before and after surgery is done. And once you get, we overcorrect the deformity. Once you get the overcorrection, we keep the fixator, whatever we are using, in a static phase. Static means, for example, if you correct the deformity in 3 weeks of time while doing the distraction, for another 3 weeks of time, we keep the fixator like that only. Okay, to mature the deformity. And we remove the fixator and we put the patient into a cast and we keep double the period. That means if 1 month for correction, next 1 month the fixator is like that, and next 2 months in the cast. So that prevents the recurrence. And after removal of the cast also, we give plain orthotics and we follow the patient physical maturity. These are few of the examples. There are common Ilizarov and extreme complications like impact infection, skin necrosis, edema, losing of the body. The more common in chest fixator than Ilizarov. Then flexion contraction of the toes, rocker bottom foot, and jamming of the distractor. So this is post-operative edema. This is the toe fanning. This is not my case. It's done by Dr. B.B. Doshi himself. You can see here, this fifth metatarsal, fifth toe has hand like this. You can skin necrosis due to the overstretching. It has happened in that girl, medical student. Get sometimes overcorrection of the foot and get a rocker bottom foot like this. Overall, the results are very encouraging. Once you use the exercise pattern, nearly 68%, we get a good results at 35%. Rather, 68% are the excellent and 25% good and few complications. This works better from 3 months to 5 years, that is our protocol, and above 3 years we apply Ilizarov. Works very effectively at any age. Correction period is mainly from between 3 to 8 weeks, that depends upon the age and severity. And average correction is in between 3 to 6 weeks. If you teach the club foot at earlier age, much more better, because the deformity is not much severe. You don't use the important schooling period of the kids, and if you are operating below 1 year and all, the kids will not trouble you. If you are operating before walking and giving the correction at a normal 1 year, the kid will start walking on a normal plantigrade foot, and that will prevent the recurrence. It is semi-invasive, bloodless, scarless cosmetic results. Cosmetic not only means scarless, but it gives the normal foot. For example, if patient is having a unilateral club foot, and if you are applying chest or Ilizarov fixator, while doing the distraction on either side, the foot also grows. So, after treating by external fixator, both the foot normal and this club foot treated by external fixator, almost they are of the equal size. Not like other treatments which only correct the deformity and they keep the corrected club foot short and stable. That is extremely important, and that is the meaning of cosmetic results. So it maintains the foot length, it gives the functional lasting result. Method is practically simple, very practical, moderately priced, it has got very less complications. Just to conclude, from 3 months to 5 years, we use just fixator. 5 years, 3 to 5 years, and with better results. We get more cosmetically acceptable, pliable, plantigrade and lasting correction. We get a faster result than conventional. These methods are simple and cost effective. Correction without bony resection is possible in most of the cases. Early treatment avoids development problems. Thank you.